Today we're going to discuss about discrimination. So detection enhancements in Boston ICDs. Hugo Pierre, are you ready?
Ready.
Okay. So if you look at the guidelines, so the manuscripts on how to program the ICDs, you know that there are specific guidelines for all the patients implanted with an ICD, and then there are specific guidelines company by company. If we have a look to here, which is SVT discriminators, what is recommended in Boston devices? First, in single lead ICD, it's going to be rhythm ID. And also for dual lead ICD, what is recommended is rhythm ID in first intention. For the CRTD, you have the choice between onset stability and rhythm ID. You see also that the SVT must be applied up to 230 beats per minute, and that the system rate duration is supposed to be programmed off. So we'll have a look. We have many tracing today, and we will start first with the single lead discrimination. So a patient implanted with a single lead ICD, so no atrial lead, no atrial information. What do you think, Hugo Pierre?
Okay, this is an episode classified as VT treated by a burst. Rhythm match 0%. So
yes, the thresholds, which is 94%, that's the nominal thresholds. So the rhythm ID is based on the analysis of the morphology of the signal. We compare the morphology of the signals during the tachycardia with templates recorded during sinus rhythm. Okay, and then you will measure the percentage of match, and with a threshold here, which is nominal, which is 94%. And you see that the rhythm match is 0%. So it's completely different during the tachycardia, and the diagnosis is ventricular tachycardia. Now, if we have a look to the tracing, you see the onset of the arrhythmia, the shock channel. The shock channel is from what to what?
It's coil to cam.
It's coil to can, yes. And this one, the V.
This is the bipolar channel from tip to ring.
Yes, so it's a Boston devices. It depends on the lead you have implanted. It's a pseudo bipolar in this patient, so it's from the tip to the coil. Okay. Okay. So what do you think here?
So here we have tachycardia with a sudden onset and a change in morphology on the shock channel.
Yep.
In the VT zone, and if we can see that it's uncorrelated with the template. You can see 0, 24, and then 0.
Yeah. Yes. So you see the acceleration here. If you consider this marker of the episode, you have 8 consecutive year cycle, 8 out of 10 for the VT zone. At this time, we'll start the duration. Okay, and at the end of the duration, which is something like 12 seconds here, what is the diagnosis?
Then we have V-detect and rhythm ID negative, so it's uncorrelated to the template, so it's VT.
Yes, it's going to be a VT, and then the patient receives an ATP, which is efficient with reduction of the arrhythmia. So now if you consider the analysis of the morphology of the signal here, it will start. The first analysis is as the 4th rapid cycle. See the 3 first to say you enter an episode of arrhythmia, and at this time we'll start the analysis of the morphology. As you said, the U means uncorrelated. when it's correlated. So if the value is more than the threshold that you have programmed, more than 94%, it's going to be a C. Okay, but here you see obviously no correlation. You see here the sinus rhythm, and then on which signal is it analyzed? You know that? Which
Yes,
channel?
the shock channel.
Yes, it's based on the shock channel, but there is also an alignment with the bipolar one. So both of these signals are used. This one is used for alignment here, and then from this alignment, you will analyze this signal with analysis of 8 points. Which company has a way to analyze the morphology very, 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 very close to Boston? Which one?
It's Abbott.
Yeah, Abbott is very, very similar. It uses also a threshold. It uses also both of the signals, the alignments, but the way it's also 8 points analysis in Abbott and in Boston. But the way where are located exactly these 8 points are, it seems they are different in Abbott and in Boston. And this will have implications. So here it's a VT. You see the percentage is very low, so it's not correlated. And at the end, it's going to be treated. Second one, what do you think here?
Okay, again, an episode classified as VT with a rhythm match of 99%.
Yep.
So
this time is going to be SVT.
Yeah, SVT.
If you look at the tracing, what does it look like? What do you think about the arrhythmia?
So it's probably atrial fibrillation. Looks a bit irregular.
Conducted atrial fibrillation. You see it. So it's the end of the previous episode here. And then we start. You see the episode 8 out of 10 here. And you see the percentage, the C for correlated. So how many? So you arrive here to the diagnosis here at the end of the duration is going to be read plus. Okay.
Yeah.
Read plus means that there is a correlation. So how is this defined, read plus or read minus? How can you say?
So if 3 or more out of the 10 last cycles correlates with the template, it's going to be read plus.
Yes, and it's a rolling window. So every time you're going to analyze the last 10, okay? So you analyze the last 10, and then if at least at a minimum of 3 are considered correlated, then it's going to be read plus, and it's going to be considered as a SVT, okay?
Yeah.
So here, clearly, that's clearly an episode of atrial fibrillation, and it has been well discriminated by the device. This one, it's about the same.
Yeah. So again, VT, rhythm match of 98%.
Yep. But now if you look at the tracing, what do you think? It's the same as the previous one, and then the episodes, and then at the end, it's going to be correlated, so no therapy will be delivered. What do you think here? The end of the duration here?
Well, it could
Which
be,
kind of episode is it?
Could be sinus tachycardia.
Or atrial tachycardia, okay?
Yeah.
Sinus or flutter or atrial tachycardia. If you look at the graph here, you see this is quite typical of a sinus tachycardia. You see the acceleration and then the deceleration, at the end of the exercise. Okay, so you see that the rate here is 150 beats per minute. So it's quite low. Okay, the more you program low zones of arrhythmia, the more you will have inappropriate therapy. But in this case, discrimination works pretty well. And then, okay. So now, what do you think about this one?
Okay, again, VT rhythm match.
Initially, it's a zone, but the correlation. Can you hear me?
Yeah, can hear you.
Just 1 second. Okay. You see here, initially it is correlated, and then what happens? At one time, the patient will receive some therapy. You agree?
Yeah.
The burst, the ramp, the shocks, okay? And then you will receive many shocks at the end, okay? The maximum of 8 shocks, okay? If you look at it now, what do you think here?
Okay, so
you are in the VT1,
yeah,
with a high percentage correlation. Still, V episode, high percentage.
yeah.
Initially, the patient is not treated because the percentage is high. And then at one time, you will see, so we see here the diagnosis for the VT zone, read plus, okay, no therapy is delivered. Read plus, read plus, read plus, read plus. And then what happens here?
Well, so now if we see it's uncorrelated. So we have less than 3 cycles out of the last 10 that are correlated to the template.
Yeah,
So
if you look at the threshold of 94%, it's 92.333. You're just below these thresholds. So this one is correlated, this one also, but no, this one is not, this one is yes, but less than 3 out of 10. You see, it starts here, and therefore the therapy is delivered. Okay. If you look at the numbers, they are close to 90%, but they are less than 90%. Okay. And then one therapy is delivered. So once the therapy has been delivered, what happens in terms of discrimination?
So the morphology only works on initial detection.
Yes, the morphology only works for initial detection. It means that if you deliver an ATP or a shock, it works for both. No more discrimination will be delivered for this episode, okay?
Yeah.
We will only base the fact, the redetection then, and the new therapies based only on the rate, okay? The morphology only works for the initial detection. It's clear?
Yeah.
Okay. Is this the same for all criteria for the discrimination?
It's the same for sudden onset and stability for single chamber device.
You will see when we are going to study the dual chamber discrimination, for example, that there are many other parameters like stability, like V faster than A, like, I don't know, stability and atrial fibrillation. And all these discriminators can work on initial detection and after a shock is delivered. Okay. After a shock is delivered, they will be applied, if you program it, of course. They will not be applied after an ATP. If you deliver an ATP, then there's no more discrimination on the, you understand? But if you deliver, there is a post-shock discrimination, but not for the morphology, okay? Not for the rhythm ID, none on the discrimination based on the morphology of the signal. Therefore, the problem is that if you have a quite stable sinus tachycardia, for example, if one therapy is delivered, then you have a high chance to receive all the therapy, you see, all the list of the therapy. So it's not so infrequent that for any kind of arrhythmia, SVT, if you receive one therapy, you may receive all the therapies. So if the arrhythmia is prolonged, for example, atrial fibrillation or sinus tachycardia, you may receive, like in this patient, 8 consecutive shocks. Okay?
Yeah.
One thing I think is important I will show you is that we have worked with Sylvain on this. This is a paper that we have published where we have compare the electrogram morphology discriminators in different companies. So Abbott versus Boston versus Medtronic. We have included more than, I don't know how many patients, a lot of patients, and we have tried to analyze the sensitivity and specificity of this algorithm. And we have seen that we had very quite important differences according to the company. If you consider, you see here the Boston Science. The idea was, is there a percentage that is better than another one? So you remember the nominal value is 94%. At 94%, we had 100% of sensitivity, meaning that if you program 94%, all the episodes of VT were correctly discriminated, meaning that there was no inhibition, okay? But if you compare now the specificity, it was very low at this number, 90. We had something like 40% of specificity. So many episodes of falsely diagnosed VT because of SVT and with inappropriate therapy. And if you look here, the point is that you want to have something close as possible to 100% of sensitivity. And if you decrease the number up to 83%, see 83%, you still add 100% of sensitivity, but the specificity was considerably improved, close to 80% and close to all the other competitors. So at the nominal value of 94%, the results were, of course, very good in terms of sensitivity, but very poor in terms of specificity. So that's the reason why now we try to quite systematically modify this value to obtain this compromise, and you still have 100% of sensitivity and very low and way better percentage of specificity. It's clear? For example, in the tracing that I've shown you, if you consider this threshold of 83%, you see, all the cycles will be correlated, okay? And no inappropriate therapy will have been delivered, okay? So let's consider that this patient has received 8 shocks. So that's a quite serious situation in this patient, okay? So clearly today, I don't know if we systematically program on a first intention 83%, but really I would not recommend to remain at this value of 94% because the percentage, the specificity is very, very low with this number. And it's surprising to see that with Abbott, first I thought that it was exactly the same way. You know, in Abbott devices, it has been modified in the last versions. The very first platforms with morphology, it worked very poorly in Abbott, very, very poorly, because all the discrimination on the morphology was based on this signal, only on the bipolar channel. In the last, in the old versions, on all the platforms of Abbott devices, it has been modified in the new ones. And obviously, when you look, I thought it was the same pattern, but it's not. I thought the Abbott discrimination worked exactly the same as Boston, but it's not exactly the same. It's also 3 out of 10. It's also alignment on these signals and analysis of this one with 8 points. But the way are located, these 8 points are different. And I think that in Boston, it's way more demanding. To say it's a match, it's way more demanding in Boston than in Abbott. And therefore, at the same level of percentage, the specificity is way lower for Boston compared to Abbott. Okay, so in Abbott, I will not modify too much the nominal value, but in Boston, I will do it. And I will decrease this value to increase the specificity in discrimination. Is this clear? Good.
Yes.
Still there? Okay, another point. What do you think here?
Okay, so another episode of VT.
The thresholds, the nominal value, initially it's 99%, so no therapy is delivered. And then what happens? Then therapy will be delivered. And as I said, when you start with Boston, remember that when you start, sometimes the patient will receive many therapy. If you just use as recommended, and that's what we do in daily practice, just the morphology in single lead, remember that there is discrimination only for the initial detection. Once one therapy is delivered, then no more discrimination just based on the rate. Okay, what happens here?
So here, the sustain rate duration is programmed on.
Yes, and it's
So,
met. Okay,
yeah.
that's true now. You see here, true. So if you look at the tracing, obviously it seems to be a atrial fibrillation. You agree?
Yeah.
Yeah, it's quite irregular. The percentage are very high, no doubt here. And then we detect no therapy is first delivered. But at one time, you will see that at one time, here, SRD means that you have programmed a sustained rate duration. And so at the end of the duration, we'll start a clock saying that if, for example, after 1 minute, you still consider it's SVT, whatever, if you consider it's SVT, I will treat as a VT. Okay, I will stop analyzing the morphology of the signal, and then I will consider systematically that it is a VT. So for prolonged SVT, if you prolong this is what will happen. The patient will receive inappropriate therapies. Okay, so clearly in the guidelines, so there may be situation where you can program it, but at least for all the patient initially, I will deprogram this, because if you program it, even if the diagnosis is correct, like here, no doubt that this is SVT. Once you've reached the clock, then you will receive the therapy, and in this case, inappropriate therapy. Okay?
Yeah.
Questions?
Nope.
No. So what I want to say, be careful using in single lead ICD only the morphology. Once more, it will work only on the initial detection. Second, some patients, if they receive one, they will receive the whole list of the therapy and sometimes 8 shocks. And third, the percentage, the nominal value is probably too high, 94%. It's good in terms of sensitivity, of course, but very poor in terms of specificity. 40% is very low and much lower compared to the competitors, at least compared to Abbott. The results with Medtronic were not so good also. But okay, so now let's consider the dual chamber discrimination. And here, as I said, I will just show you first this slide. You see the slide here?
Yes.
If you consider the rhythm ID, you can also rhythm ID, meaning the morphology plus atrial informations. Okay, so if you program both rhythm ID and the atrial information, this is the way it will work. It's clear?
Yep.
The first step, it's very simple. The first step is the ventricular rate faster than the atrial rate? So at the end of the duration, you will analyze the last 10 ventricular cycles and the last 10 atrial cycles, and you will compare them. And if the ventricular rate is faster than at least 10 beats per minute compared to the atrial rate, then it's going to be a VT. So this one is analyzed first. If it is true, there's no more analysis, you will be treated as a VT. In ventricular tachycardia, in something like 80% of the cases, the ventricular rate is faster than the atrial rate. So if it works correctly, you will properly discriminate initially with just this 80% of the ventricular tachycardia. If this is not true, if the ventricular rate is not faster than the atrial rate by at least 10 beats per minute, then there's going to be the second step, is going to be analysis of the morphology. Okay? And from there, 2 possibilities. If there is a correlation, at least 3 out of 10 cycles which are considered, then end of the analysis, the episode will be diagnosed as SVT. And that's the same. If the correlation, if the morphology works well, a vast majority of the SVT will be here and will be correctly discriminated. So the 2 first steps, with these 2 first steps, you will correctly diagnose most of the VT and here most of the SVT. If now the ventricular rate is not faster than the natural rate, and the rhythm is not correlated. There are two possibilities. Either there is a problem with the morphology signals. It is not correlated, but it should be, but the algorithm is not working properly. That's the first situation. The second possibility is also that in some patients, you may encounter rate-dependent bundle branch block. You see, so narrow QRS, and during high rate, you will see, I'm sorry for the quality of the English, but you will see a bundle branch. So in this case, what do? So no correlation. You will analyze, I will show you, the atrial rate and define if the patient is or is not in atrial fibrillation. And then you will also analyze the stability of the rhythm. So if the ventricular rate is not faster than the atrial rate, if there is no correlation, if the patient is very fast at the level of the atrium and unstable in terms of ventricle, you will consider that it is a conducted atrial fibrillation, either with a problem in the signal for the morphology or with a rate-dependent bundle branch. Okay, and then the patient will not be treated. If the atrial rate is not fast enough to be in atrial fibrillation, or the rate is stable, then you will be treated because it will be considered as a VT. It's clear?
Yes.
Pierre?
Yeah.
Okay, so now I will illustrate that with tracing. I think it's going to be easier to understand. What do you think here?
Okay, another episode of VT. So it says V more than A true.
Yep.
So
you see,
device, yeah.
ventricular faster than rate. Okay, it's going to be true. So now if you have a look, it's a dual chamber ICD. No, it's a triple chamber, sorry. And you see here, clearly, ventricular rate faster. That's a real VT, no doubt. 8 out of 10. You see here the percentage. You see, it's not 0% here. But it's less than the threshold that I've shown you of 83%. You remember? Of course, it's less than 94%, but it's also less than 83%. So in this case, if you had considered just the morphology and based on 83, it would have correctly been diagnosed, okay? So you see here, up, and you arrive here at the time of the end of the duration for the VTism and then the diagnosis. And you see, you have the information that it is stable, but this one is not considered at this time, since if ventricular rate is faster than natural rate, you stop all the other analysis, it's going to be considered as a VT, and you will be treated with an ATP. Okay? So that's the first step. Ventricular rate faster than natural rate, you treat. Okay? So I'm sorry, it's in French now. What do you think here?
Okay. So at first we have A sense V sense, and then it accelerates, and we have a few cycles in the VT
It's
zone.
difficult to say. It's a one-to-one tachycardia. Okay.
Yeah.
It can be atrial, it can be sinus tachycardia. It can also be a ventricular tachycardia with a retrograde conduction. Okay, on the shock channel, the signal seems quite narrow, but no proof at this time.
Yeah, pretty similar.
Yep. So it's an old platform, so you don't see the percentage of correlation. But at the end of the analysis, you see here, read plus. It means that there is a correlation. Okay?
Yeah.
So no therapy is delivered. Okay?
Yeah.
And it's the same. In this patient, it was a sinus tachycardia. But
okay,
what happens here now? At one time, there is a first premature atrial contraction, you see here, during the sinus tachycardia. The rhythm is now unstable, but there's still a correlation, okay? So the step 2 is verified, it's correlated, therefore no therapy is delivered, okay?
Yeah.
But then what happens?
Okay, and then the device device sees more V's than A because there's, I think, a PAC that falls in the
blanking
PVAB. Yeah.
You see this premature atrial contraction just inside, just at the same time of the ventricle. Therefore, it's not seen. So now, if you compare the atrial rate, you see there is here a gap here, and therefore, at this time, the ventricular rate is considered to be faster than the atrial rate by more than 10 beats per minute. So even if the discrimination in terms of morphology is correct and say you should not treat, this is the first analysis, the first step. So at this time, the device considers that the ventricular rate is faster than the atrial rate. Therefore, whatever the stability, whatever the morphology, this is the first step. And if it is true, it's going to be treated. Okay?
Yep.
So the message here is to say that with V faster than A, you will correctly discriminate most of the VT, but there is something very important. You need to program it only if the quality of the sensing at the level of the atrium is correct. If you have an atrial undersensing at one time, every of the episode will be considered as VT. If you have, for example, atrial undersensing in an episode of atrial fibrillation, okay, but you will treat everything, you understand? And if also there are this kind of problem, so here the quality of sensing is correct, but the premature atrial contraction is a problem because it's just at the time of the blanking. If because of refractory periods you have functional undersensing, then you will also receive inappropriate therapy. Okay?
Yeah.
So most of the time I let the programming with V faster than A, but you may have some patient here. Clearly, you don't want to have this parameter for the discrimination because it's going to be wrong anytime. Okay?
Yep.
So now I will show you. So the first step, V faster than A. The second one, I will do it quite fast. Here is the second step is the question of the correlation. You see, start of the tachycardia, 1, 2, 3 on the force beats analysis. It's correlated here. You see, it's a one-on-one tachycardia. It's correctly. You see, the percentage is high. And at the end, video, no therapy is delivered. If you look at the graph, you see the acceleration, one-on-one acceleration, and then the acceleration. That's an episode of a sinus tachycardia. So the step 2 is this correlated or not? In this case, it works pretty well. It is correlated. No therapy is delivered. Okay. Now it's an episode of atrial tachycardia. You see here the same. I will not show you all the example, but if it works well, it works well. The percentage is high. And at the end, you see here, AFib, it is stable, but you see here, this one is more important. There is a correlation, therefore, no therapy is delivered. Okay? You see the way it stops spontaneously, it stops on a ventricle, so also it is a point for the diagnosis of atrial tachycardia compared to ventricular tachycardia. Any question? The same for atrial fibrillation, so I will not spend too much time. So now, what do you think here? So it's French.
So yes, an episode of VT, but at first we have more A's than
So it's
B's.
based on I'm sorry, it's French, but it's rhythm ID here, rhythm ID.
Yeah.
Then you see that V faster than A is wrong. The correlation is also wrong. So this is the time where you will analyze, is there atrial fibrillation and is the rhythm stable? Okay?
Yeah.
Okay, so here you see stability 3 milliseconds. So you see that's real atrial fibrillation. And then you see the tachycardia here, the change obviously of the morphology, you see here.
Yeah.
So at the time of the diagnosis, you say, okay, V faster than A is wrong. This is probably a dual tachycardia. Is there a correlation? Nope, we don't. It's read minus. Okay, so no correlation. So that's the time where you analyze the criteria for AFib and the stability. AFib is right. There is a diagnosis of atrial fibrillation. For the diagnosis of atrial fibrillation, you will analyze the last 10 cycles, and you need to have at least 6 cycles labelized at the level of the atrium AF. Okay? So here it's true, that's a atrial fibrillation, but the rhythm is stable, okay, completely stable. Therefore, diagnosis of dual tachycardia, and then an ATP is delivered. Okay?
Yep.
Other patients, it's rhythm ID also. And you see here, that's the only example that I have with a patient with functional bundle branch block, rate-dependent bundle branch block. You see here, that's an episode of atrial tachycardia, atrial fibrillation, and it's quite irregular at this time. And when you arrive at the time of diagnosis, V faster than A is wrong. The second one, is there a correlation? And the response is no, it's minus, because of all these variations here, bundle branch, and the quality of the signal is not also very good. So that's the time where there is an analysis of atrial fibrillation. So you analyze the last 10 and 1, 2, 3, 4, 5, 6. So there is a diagnosis of atrial fibrillation, but it's unstable. You see, it's very unstable here. So if it is unstable, it is considered as a conducted atrial fibrillation and no therapy is delivered. Okay?
Yes.
Still there?
Yep.
You still follow the different steps?
Yep.
Okay, number 3. What do you think?
Okay, so V more than A false, rhythm ID correlated.
Yep. So VA, so false, it is correlated.
Yeah.
Next step is analysis of stability and atrial fibrillation. Okay.
Threshold, yeah.
Okay. So if you have a look, you see the patient. I have reviewed more or less all the episodes of treated episodes in patient with Boston in all the patients from Bordeaux, Clermont, and Toulouse. You see, so many patients, and this situation with many episodes of inappropriate therapy in the row is not infrequent. In Boston, if you receive one, you have a high chance to receive many. You see here, okay. So it's one-on-one tachycardia. And the percentage here is not very high. You see the poor quality of the signal here? You see the percentage here?
Yeah.
You see this poor quality at the end, low number. But, okay, it's correct. And then still remain on the threshold of more than, and you arrive here to the diagnosis. So what the diagnosis is, V faster than A is wrong, since you are one-on-one, okay? Second step is the correlation. Here, you have more than 3 out of 10, you see? Since the threshold, this one is good, this one is good, this one, okay? So it's read plus. And then there is an analysis of the atrial rate. So for atrial fibrillation, the nominal value is 170 beats per minute, okay? For atrial fibrillation, it's not a question of stability at the level of the atrium, it's a question of rate only. So the nominal value is 170 beats per minute. And in many patients, it's a bit low. So you will encounter many times a false diagnosis of atrial fibrillation. You see, and then AFib, and initially it's stable. You see?
Yeah.
AFib stable. So what do you think here?
So, well, it's conducted AF faster rate that it's seen as stable by the device.
Yes, but initially the step 2 is verified here. You see, it's read plus. If it's read plus, it's the end of the analysis. You understand?
Okay, yes. Yep.
Okay, so no therapy is delivered. But as I said, the quality of the signal is not very good. So you see here, it's very poor. When it's very poor, you see a decrease in the percentage. Once more, if you had programmed 83%, in this case, you see this one will be correlated. This one also is just, it's at the limit here, but the patient will not be treated. With 94%, then the patients, you arrive to diagnosis of rate minus, no correlation. You understand?
Yeah.
So that's the time here. There is a problem with the discrimination based on the morphology, and it's a one-on-one tachycardia. The rate is very stable. So if it is stable, the patient will be treated. You understand?
Yeah.
Okay. The patient will say that's probably a VT. Since there is no correlation, that's probably a VT. So I will treat, and then the patient will receive many inappropriate therapy. So in case of sinus tachycardia, you need to be sure when you program atrial fibrillation. But if you program like this, if at one time there is one problem with the morphology, then you can be sure that it will be treated. If you program like this, the only situation where you may not treat inappropriately if you have a problem with the morphology is atrial fibrillation, because it's very irregular, and if it is irregular, maybe the patient will not be treated. But if you have a problem with the morphology like here, with sinus tachycardia or atrial tachycardia, the ventricular rate most of the time is stable, and then the patient will be treated. Okay?
Yeah, okay.
It's clear? What can I show you? These are exactly the same example you see here. It's the onset of the tachycardia. It starts with the atrium. Okay, so it's really in favor of atrial tachycardia. It's one-on-one tachycardia, and it's going to be the same. You have here the diagnosis: read plus, stable, so it's okay. Read plus, read plus, read plus, read plus, read plus, and then at one time, the person, you see here, for example, if you program 83%, you see 94%, you are below this number. Okay, so right minus, okay, and then it's stable, therefore the therapy is delivered. Okay, so that's a real episode of atrial tachycardia. And sometimes remember that if you treat with an ITP, atrial tachycardia that just started, there is quite a high chance that if it's a one-on-one tachycardia, it means that there is a good transmission from the atria to the ventricle. Another possibility is that you also have a good transmission from the ventricle to the atrium, and then you may reduce some episode of atrial tachycardia with a ventricular burst. Okay, here that's the case of an episode. I will show you another case for this patient, but that's a case of atrial tachycardia and a reduction. So is there a reduction just before, or is this the burst that will reduce it? I don't know, but at least you see that with the ATP, at the end of the ATP, there is no more atrial tachycardia. Okay, but remember, 94% is probably too high. And if you program 85, 86, 87, at least, you will have a much better results in terms of specificity and decrease in inappropriate therapies. Okay, the inappropriate therapy that I have seen in this case, most of the time there is a correct initial diagnosis, and then at one time, for any reason, for 10 bits, the quality of the signal is less, and then the patient will receive inappropriate therapy. Okay, the same patient here, you see this is the same patient, and you see here it's a one-on-one tachycardia, the same exactly. You see the percentage. You see, 94% if you program 83. I just repeated systematically, but you see that you will have a correct diagnosis. And in most, not to say all, but I think in all the VT I have seen, it's the same. 83% was also correct, meaning that during VT, most of the time you can be, sometimes you are 0%, sometimes 10%, sometimes it grows just close to 83, but most of the time it's less. So the sensitivity remains close to 100%. And in this case here, the same at one time, right minus, the therapy is delivered. It is inefficient in this case, but another therapy is delivered, another one, and by chance at one time another one. So the patient may receive it. There's going to be a spontaneous reduction here, and as you see here, it's the ends of the tachycardia is on the ventricle. So also it started with the atrium, it ends with the ventricle. These all points are clearly in favor of an episode of atrial tachycardia. Okay. Yes.
Yeah.
A lot of information, but that's the last one now. Maybe I could show, not today, but in a triple chamber, you have the choice also to program onset stability. And I would really recommend to program I think you should program, if it works pretty well, rhythm ID much more than onset stability. Sometimes you may change from rhythm ID to onset stability, but in first intention, I will recommend to systematically program the rhythm ID, even in triple chamber ICD, with automatic measurements, active measurements of the template. With CRT, what you want is to pace the ventricle, so you will program a short AV delay. So if you do not modify the programming at one time, you will not have the possibility to see a spontaneous activation. If you see a spontaneous activation, most of the time it's going to be a PVC, not the sinus activation. So if you program the template on active, at one time, the device will systematically decrease the rate, prolongs the AV delay to favor the occurrence of a spontaneous activation. And that's what I systematically program now in CRT devices, because really, when I have analyzed all the tracing based on onset stability, the percentage of inappropriate therapy is pretty high. So I systematically now program the morphology. If it works, you can check it during the interrogation and see that the signal is correct and that the measurements are correct. So you can test it during with the programmer. But if it works pretty well with the programmer, I systematically program even in CRT devices, and with an active re-measurements of the templates. Every 28 hours, it will modify the programming to favor the occurrence of spontaneous ventricular activation, and then it will measure the template on a real conducted signal from the atrium to the ventricle. Okay, I don't know what I wanted to show you here. That's the case of an atrial fibrillation, and you see the signal here. The percentage is high, intermediate, I would say, the same. 83% will work correctly. That's a conducted atrial fibrillations. And the problem is that, as I said, with this kind of thing, if you have a dual tachycardia, if the morphology signal is not perfect, you see that you are the threshold has not been correctly programmed. Here it's 94%. So all the signals are not correctly diagnosed. It will be correctly diagnosed if you are programmed 83%. That's the threshold that now we try to program systematically. So if you have these kind of problems, even if initially the rhythm is quite unstable, if at one time it becomes stable, then like here, the patient will be treated. And if it is treated, then you may receive many inappropriate therapy. Okay? Are there any questions?
Yes, I have a question actually for the discrimination, post-shock discrimination in dual chamber device. So all the criterias works except rhythm ID, the correlation.
Yep, the onset does not work, and the correlation doesn't work. What works will be SRD, so sustained rate duration, V faster than A, atrial fibrillation, stability.
Okay.
Okay.
And it's not the case after an ATP?
No, after an ATP, there is no discrimination anymore. After one, let's consider you deliver 3 bursts. After these 3 bursts, no discrimination. But then if you deliver a shock, then it's the post-shock discrimination.
Okay.
Okay.
All right. Thank you.
In fact, it's too short. Most of the time after a burst, it depends on how you have programmed it. But sometimes you program very short duration after a burst. and therefore the patient, there's no time enough for the analysis.
Okay, I see.
Okay. Any question? Okay, so we will meet next Monday and then we will see what's going to be the subject. Okay, bye.